the topics that given to me to talk about is PCOS beyond fertility, fertility and cancer, a dilemma for doctors. But I think it's not the dilemma for the doctors alone, but it's also a dilemma for the patient and the family members. So first, we need to know about the PCOS and relationship with cancer. What type of cancer is commonly associated at higher risk when patient have PCOS? So we know that the PCOS has been linked to the breast, ovarian, and endometrial cancer. So, but when we look at the various systematic review meta-analysis looking into this issue, we can see that we can exclude the breast cancer. I think various meta-analysis in the last 10 years basically reveal the same patterns of result, which is there is no associations of PCOS with the incidence of breast cancer. So, but the dilemma or basically a mystery is with the ovarian cancer. All the various meta-analysis along the way shows that there is a trend towards increase the diagnosis of ovarian cancer among patients with PCOS, but it is not statistically significant. So for ovarian cancer is basically just a likely not increase, but most authors will put it likely not increase, but cannot put with certainty it do not increase risk of ovarian cancer. However, for endometrial cancer is one of the main topics or main concern, because the meta-analysis, for example, is a quite recent meta-analysis which shows that the more than 2 times increased risk of diagnosis of ovarian endometrial cancer among patients with PCOS, especially in a very young premenopausal age group. So even though there is the uncertainty about the relationship between PCOS and ovarian cancer, it's worth to mention is the point that meets between PCOS and ovarian tumor is basically hyperandrogenism, which may or may not manifest as virilization. So this can sometimes give rise to diagnostic dilemma. When you have a young patient with the signs of hyperandrogenism and serum testosterone is high, would you want to work up further before you say this because of PCO, you want to work up further to exclude the presence of either ovarian or adrenal tumor. So if you look at the ACOG guideline, basically if you have the serum testosterone of 150 to 200 nanogram per deciliter, which is approximately around 6.94 or 7 nanomole per liter, it is advisable that you need to work up, for some form of workup is needed to exclude either adrenal tumor or ovarian tumor as a cause of the hyperandrogenism. So what uncertain is how far you want to work up, whether you want to enough with the pelvic ultrasound, or you have to go with the CT scan, or you go all the way up to PET scan. That is still debatable and uncertainty surrounding that. So if not, then we can avoid what happened to this lady. So this lady is basically at the late 30s that come to us referred because of the mass in the abdomen. What she has is married for 9 years without any kids. Then over the past 7 years, the menses stopped totally, and then she had the changing in body image from the female to become basically male looking lady. And then when I saw her in the morning, I thought rarely you see in our clinic is the male entering the staff toilet. Usually if male is basically doctors lah. So luckily the toilet is basically unisex toilet. So if not, I would say, oh, you go into the wrong toilet. So the when the husband come along in the clinic, then your first instant you say, oh, is it a gay couple? Because it's the totally look male. So she got a diabetic over the past 5 years and hypertension over the past 5 years. It's very compliant to the treatment, looking at the books. So nobody basically is, look at this matter. So even when she had the lower abdominal discomfort, the doctors just say you got angin. This is because of angin. When we look at the serum testosterone, it's basically far above what is supposed to be 6.94 or 7 nanomole per liter, but I'm not sure. I think even is basically above the average male testosterone, but I'm not sure whether this level is reaching Superman testosterone. So because we don't have a reference point for Superman. So what difference between PCO and the secondary cause of the hyperandrogenism is usually in PCO. I think all the talk about the increased reverse ratio between LH and FSH, but in this patient you can see both FSH and LH is basically the surprise. So she basically had the virilizing ovarian tumor as a cause of the problem. So for endometrial cancer, so we know that from the meta-analysis, there is a certain relationship between PCO and endometrial cancer, and PCO known to increase risk of endometrial hyperplasia, or secondly endometrial precancer, either EIN or also known as atypical endometrial hyperplasia, and it's also associated with a type 1 endometrial cancer, which is known as the endometrioid adenocarcinoma of endometrium. So if we go back into proposed molecular pathogenesis of the endometrial cancer, where does the PCO come into place? So in the molecular pathogenesis, it was thought that the precursor of the type 1 endometrial cancer is basically because of the either mostly is a somatic mutation of the P10 genetics, and there is a minority of patient is because of germline mutation rather than somatic mutation. There is another few minority the genetics that's involved, but worth to mention is that P10 mutation found about half of the women who are normal menstruating don't have any the endometrial tissue. So what happened in PCOS? There will be high estrogen. A lot of them also have insulin insensitivity, hyperglycemia, hyperinsulinemia, as what the Dr. Shafinas mentioned to us. So all of this is basically for high estrogen is basically directly stimulate the proliferations of the abnormal genetic clone or cell to proliferate. And for insulin insensitivity, hyperglycemia, hyperinsulinemia basically work through the insulin growth factor, which promotes a proliferation of endometrium, and in terms indirectly promotes the abnormal clones of genetically mutated endometrium to become benign endometrial hyperplasia or endometrial pre-invasive lesion, and later will progress into endometrioid adenocarcinoma of the endometrium. But the problem is, if you look at this, you have a PCOS patient, when you want to basically screen for the endometrial hyperplasia, or at this point, is basically the diagnosis is made through endometrial biopsy, either through the office endometrial sampling or through a DNC. If you look at some of the guidelines available, for example, ACOG guideline basically recommend that any women less than 35 years old with chronic end ovulatory cycle, basically is one of group is a PCO, to have to have been endometrium checked. But the impractical, if we do choose a patient, we look at the endometrial thickness on ultrasound. If the endometrial thickness basically above 14 millimeter, then I think this is a group that we need to look at and probably choose to go for endometrial biopsy. So for endometrial hyperplasia, I think there is not much a dilemma in that, because of we know that the endometrial hyperplasia or benign endometrial hyperplasia respond well with low dose progestogen treatment, and either in the forms of LNG IUS, oral progestogen, Depo-Provera. Basically all of this has been used with the reasonable good pathological resolution. So, but the problem is basically with PCOS and endometrial pre-cancer. So the first dilemma is basically we still don't know what to call it. Some people call EIN, some people call endometrial hyperplasia. So based on the work by Kurman in the late 80s, the WHO come out with the 4 tiers classification, which is simple endometrial hyperplasia without atypia, complex endometrial hyperplasia without atypia, simple endometrial with atypia, complex endometrial hyperplasia with atypia. Later they found that this is too complicated. It is not easily reproducible, because a lot of the characteristic is very subjective and a lot of inter-observer variation by pathologists. Then furthermore, for the clinician, whether you're simple or complex endometrial hyperplasia, as long as they're without atypia, they are managed in the same way. So whether you are simple or complex endometrial hyperplasia, if the presence of nuclear atypia, it will be managed in the same way. So the International Endometrial Collaborative Group in 2000 come up with the basically EIN system, which classify into only 3: benign endometrial hyperplasia, endometrial intraepithelial neoplasia, and cancer. But the group in the WHO say, ayo, so we have to follow this, or we have to basically compete with this, and we come up with WHO 2014, which is about almost the same, which basically classified under hyperplasia without atypia or atypical hyperplasia, and also known as they put 1D at the behind, endometrial intraepithelial neoplasia instead of the endometrial intraepithelial neoplasia. So until now we don't know what to call it. So you look at our pathologists at some time before, the EIN nomenclature is popular in their reporting, but nowadays I think a lot of them is going back to atypical hyperplasia. So let them be in dilemma, but for us is either it is whether it is EIN or atypical hyperplasia, we manage in the similar manner, which is the total hysterectomy. The standard is a total hysterectomy with or without DSO. If fertility is desired or not fit for surgery, then we consider hormonal therapy if the criteria is met. So for endometrial cancer, the dilemma basically for both doctors and the patient, we know that the standard treatment for endometrial carcinoma is basically total hysterectomy with bilateral salpingo-oophorectomy, peritoneal washout for cytology, and with or without pelvic lymph node dissection, and in some patients require post-operative adjuvant treatment. But with this standard treatment, there will be loss of future fertility, and they will also result in the surgical menopause in a very young patient. And the standard treatment usually offer overall 5-year survival rate about 94%, regardless of the stage. And but the report shows that it's more favorable outcome, like patients with PCO, which commonly come in a premenopausal age group, because they tend to have a lower grade tumor and a lower stage of the disease. So the some patients expect differently. They haven't completed the family, or they don't have any child yet. and on the other end there will be an option for fertility preserve treatment. Either this will require some form of anatomical preservation, total anatomical preservation, both uterus and ovary, or they preserve the ovary alone, or also called it partial fertility preserve. So, but there is a lot of dilemmas around it. How should it manage? How safe is it? Can fertility treatment and pregnancy influence it? Endometrial cancer recurrence. But what been agreed is it should be limited to young patient, less than 40 years old, either non-parity or low parity. It must be type 1 cancer. Type 2 is controversial, and it must be type 1 CA, type 2 cannot. The clinical stage 1A with no or minimal myometric invasion, and must be FIGO grade 1. So FIGO grade 2 remains controversial. So what we don't want, what we fears is the catastrophic oncology outcome, like this patient, which come to us is in late 30s with the type 1 endometrial CA and the grade 1 endometrial CA. On MRI you can see fairly nice endometrium, but it's some suspicious superficial invasion in this area, and the patient upon discussion basically requested for fertility preserve. So but after 6 months you can see the whole uterus basically infiltrated by tumor, and there is the basically full-blown lung metastasis. So it's one of the two of our patients who has overt disease progression while on treatment. The other one is basically no lung mets yet, but the uterus show basically is the total infiltration by the tumor after about 6 months of treatment. And when we discuss the patient to go for standard treatment, then patient just say, okay, if you don't want, you cannot offer this treatment to us, then we go somewhere else. Okay, so I give her about 2 weeks time to think about it and come back. So one option only they said, which is fertility preserve. If no, then I don't want any appointment. We will come back when sometime later when we're ready. So that is the patient expectation. So in terms of treatment, basically is a mainstay is only oral progestin at the moment. So if we look at in perspective, the chance of disease regression around 82.4%, with a relapse rate around 25%. So then pregnancy rate 28.8% and live birth rate 19.6%. So based on this, so give us some light to offer certain group of patients with the certain characteristic for fertility preserve. But when interpreting this meta-analysis, we have to be very cautious, because I think there's few meta-analysis in the last 10 years. All of them, one thing in particular is the heterogeneity is very high, because it is understood, because in this issue there is no randomized control trial. It's basically a cohort. Most of the study is a cohort with the selection criteria is different. That will lead to the high heterogeneity. That's why we cannot find any meta-analysis done by the Cochrane, because in Cochrane, if heterogeneity is high, they will not do meta-analysis. The meta-analysis is only done by independent author, because of even though it's meta-analysis, when the heterogeneity is high, the quality of result is basically statistically is not good. So this need to be interpreted with cautious. So the one thing interesting is we have one of the mentioned in the result, we have to pay more attention to body mass index and polycystic ovarian syndrome, because of higher BMI associated with a lower response rate and a higher recurrent rate. And there is a conflicting result on progesterone use in PCOS because of some studies shows that PCOS damage the and progesterone receptor, leading to progesterone resistance, and because of that you got a lower response rate. But another study indicate the endometrial cancer in PCOS do also respond to some extent to progestin. So the selection criteria is also an issue because of there is no best standard. So, but it's been agreed that it should be stage 1A and FIGO grade 1. If you have the 1A is based on the older versions of FIGO staging, which is the 1A, which is no myometrial invasion. The current FIGO staging is 1A is up to 50% of myometrial invasion. So when in the presence of minimal myometrial invasion, FIGO grade 2, that is the controversial area. Then patient must be adequately clinical stage. We know that the staging for endometrial CA is a surgical staging, but in this case you cannot do the surgery, then we have to do clinically stage. How to mesh the surgical staging, that's remained a challenge. What best, because we know that prognostic parameter for the endometrial CA is a grade, depth of myoinvasion, cervical involvement, lymph vascular space involvement, nodal metastasis, adnexal metastasis, and also positive peritoneal fluid cytology. So in the absence of surgery, then histological grade, we know that the best one is hysterectomy specimen, and then second best will be DNC, because DNC sample about 80% of endometrial surface compared to the office endometrial biopsy, which sample only about 4% endometrial surface. So of course 80% to determine the highest grade of the lesion, theoretically better than 4%. So the myoinvasion, nothing can match the examination of hysterectomy specimen, but in terms of the clinically MRI shown to be better than CT scan or transvaginal ultrasound scan. So here in our hospital, all the patients wish the fertility preserve option been offered with highest degree of lesion by DNC, and myometrial invasion will be assessed by contrast enhanced MRI, and for assessment of distant metastasis is through a CT scan. So for the treatment option in fertility preserve, basically is the only one option, which is high dose progestogen. Unsettled issue about the PR receptor status in endometrial tissue examination. Because we know that the response to progestin treatment depend on estrogen and progesterone receptor status. If we look at the EP positive endometrium, the response rate is ranged from 26 to 89%, but much more lower in EP negative, which is the 8 to 17%. So one of the analysis by Iskander basically is include the estrogen receptor and progesterone receptor positivity status as one of the criteria for FP. However, some people do not agree with that, because in the ground that is quite reasonable number of patients who has EP negative do also respond to the progestogen treatment. So therefore, whether you want to do a estrogen receptor or progesterone receptor as a prerequisite criteria remains a debate. In terms of best treatment strategy, also doesn't exist so far. So what we know that is the commonly used high dose progestogen, because MPA 100 to 800 milligram. We understand the MPA with the Provera used for our menstrual disorder treatment is range from 5 to 30 milligram, but this one you push the basically dose from 100 to 800 milligram. So therefore there will be a lot of some side effect. Some people combine systemic MPA with the LNG IUS. It's a lot of temptation to use alone LNG IUF. However, that is still experimental and not been accepted yet. So, in terms of partial fertility preservation in endometrial cancer, it's basically aim is to preserve both ovaries during the hysterectomy for endometrial cancer, and pregnancy later will be had by either surrogacy or in some part of the world now is come out with the uterine transplant. So this will also avoid problem with estrogen insufficiency, but there is a concern about the occult existing ovarian metastasis undetected during the surgery using this approach, and there were concern also about occult synchronous primary ovarian cancer, which can also associated with patient with severe endometrium. And there's also third concern is estrogen stimulation of the micrometastasis. So the other potential strategies is oocyte and embryo cryopreservation, but is still in the experimental status. So some other issue need to be considered is the safety of ART on EC progression. So at the moment there's a limited data to enable any conclusion made, but some suggest that the during the stimulation process the E2 level need to be kept low. So another issue is the safety of pregnancy on endometrial cancer progression. So once you treat that, after that allow patient to get pregnant with the high estradiol level during pregnancy will have the negative impact on the endometrial cancer. But this also at the present is a very limited data to enable us to have any meaningful conclusion. So like what the Zainal Arifin say, jangan biarkan hidup anda diselubungi misteri. So we have to conclude in some way. So number one, PCOS certainly increase risk of type 1 endometrial cancer, and especially at the young reproductive age. So there's a limited evidence today indicates the fertility preservation probably safe for properly select low-grade early-stage endometrial cancer when fertility preserve is deemed necessary. Both partial fertility preservation or full fertility preservation are an option. However, fertility preservation is still not a standard treatment in endometrial cancer. So the many uncertainty regarding best patient choice to reduce risk of catastrophic oncologic failure, treatment regimen and optimal follow-up. So because of that, we need a careful patient counseling, which is a very, very deemed necessary. With that, thank you very much.
Thank you, Dr. Ismail.